patients who have hip replacement, as we mentioned, we do it for pain relief, and patients are typically able to get back to enjoying, quite good function and enjoying activities, some activities for exercise, although modified activities, not open field sporting activities. But of course, there are risks with all procedures and medicines, whether it's pill or procedure, and the standard risks apply with a hip replacement as with any surgery, which includes infection, bleeding, blood clot. Risk of nerve or blood vessel injury to the leg is extremely uncommon, with the exception of some numbness or tingling around scars or on areas of the thigh. The possibility of needing a blood transfusion is low nowadays. Oftentimes in patients without a history of blood clots, we'll use a medicine to help limit the risk of bleeding. Our incidence of blood transfusion at Concord Orthopaedics for hip replacements when we last reviewed was about 3%. So we don't recommend that patients donate their blood pre-surgery. Of course, what we worry about most with any surgery is infection. Fortunately, the incidence of infection is low, and our incidence of infection here at Concord Hospital and Concord Orthopaedics is quite low with hip replacements, 1% or less over the years when we've reviewed our results. However, in that unusual circumstance of an infection occurring, it can be a real mess, in which typically requires further surgery, antibiotics through an IV for a couple months, and it often requires us to remove the artificial hip implants from the bone. So patients may be left without a functional hip joint for a few months while they're getting antibiotics, which could result in patients needing crutches or a walker for a few months or a wheelchair for distances. And then if it's been treated adequately, then we can go back and put a new hip back in. So say, fortunately, however, that's uncommon. And that's why we're doing everything we can to try to optimize patients' health before surgery. And the thing that's unique about infection with joint replacements is we can't just give patients pills to make the infection go away, because typically the bacteria which cause the infection, they stick to the metal and plastic pieces, and so the body just doesn't have a way for the antibiotics to get there to take care of the problem. So it's typically a surgical solution to the problem as I described. Things that are more common with hip replacements as far as risks are the possibility of one leg being longer or shorter than another. Oftentimes many of us will have one leg longer or shorter than another naturally. And as I mentioned, the process of an arthritic hip, the wearing away of that cartilage cushion, which prompts patients to need or want a hip replacement, often results in the leg maybe being a little shorter to start with. So the process of rebuilding that cartilage cushion often may lengthen the leg just a little bit. We often will use x-ray guidance or other means to help equalize leg lengths as closely as possible to limit that possibility. Most patients are unaware of a leg length difference after a hip replacement, but there is an occasional person who wishes to wear a shim in one shoe or another to equalize a difference, and a very uncommon situation where a patient may note a more significant difference and actually wish to have a build-up made on one shoe or another to equalize a difference, but that's uncommon. Other things that can happen with a hip replacement, the new ball could come dislodged from the socket. It's uncommon, but it can happen with any hip replacement, with any approach. And with our anterior approach, it was four out of our first 1,000 patients sustained that. It typically results from an extreme body position or a twist or a turn where the foot is sort of fixed on the floor. So it's typically an extreme or unusual body position that prompts it. If it happens, it typically does not require further surgery, but it does typically require a trip to the emergency room where it's manipulated back into position. If it becomes a recurrent issue, then it may require further surgery. Other things that can be unusual, we put the implants into the bone very tightly, typically, so the bone will adhere to the implant over a couple months' time. And so in the process of putting the implant in very tightly into the bone, there could be a crack in the bone. In that situation, then oftentimes we may just support the bone with a wire or a cable to support it, and then we may protect that patient's weight bearing for a little bit longer with some crutches. And then finally, it's a machine. It wears over time like any material or brakes or tires on a car. The odds are favorable for it lasting a good long time, hopefully 10 to 20 years, but sometimes unusual things can happen. And there may be a 1% chance, I tell patients, that some strange or unusual thing would happen in the first year, which would prompt the surgery to be redone in the first year. Over 10 years, maybe a 10 or 15% chance of needing it redone. And over 20 years, probably a 50% chance. So the odds are favorable for a good long time of use, but sometimes unusual things happen. And then the final thing I tell patients about risk with surgery is there's no harm coming to them not having surgery. This isn't a life-threatening situation. We're not talking about a heart problem or a leaky heart valve or a cancer or a sick appendix where patients are going to become ill from a sore hip. But it's not going to get better over time. So it becomes a quality of life issue. So when symptoms get to the point where they're impacting their ability to enjoy life and do things they need to do on a daily level, where they've made some adaptations and modifications already, then this is what we have left to offer as a hip replacement.